Please know that this episode contains content that some people may find disturbing. While our goal is to address relevant and important science faith topics, we also want a positive experience for our audience. Welcome, everybody, to this special edition of Stars, Cells, and God. This is the podcast where we explore how the discoveries that are taking place in the frontiers of science provide evidence for God's existence and the reliability of Scripture. This podcast is sponsored by Reasons to Believe. If you want to know more about Reasons to Believe, go to our website, reasons.org, or you can follow us on social media at RTB_official. Also, if you're watching this podcast, please, on our YouTube channel, Reasons to Believe, make sure that you subscribe and that you hit the bell icon so that you are reminded when new episodes of Stars, Cells, and God drop. Today, we're going to be taking on the question, are chemical abortions safe? And my name is Rana. I'm a biochemist and a Christian apologist. I work for the organization Reasons to Believe. And today we have a special guest with us, a person who is eminently qualified to take on this really challenging question. And her name is Dr. Christina Cirucci. And so, Chris, I'm so grateful that you're here and part of the podcast today. So thanks for taking the time to be with us.
Thanks, Fuzz, for having me. I'm very happy to be here. I'm excited to talk to you.
Well, before we get into this really important question that we're going to engage, I think it would be good for our listeners to get to know you a little bit. So what I thought I would do is I would read your bio, and then maybe you and I could just talk a little bit about your work as an OBGYN physician, if that's okay with you. And then we'll get into the issue of chemical abortions. I'm going to go ahead and pull up the bio here. And you are a board certified OBGYN that you've worked for 20 years in private practice outside of Pittsburgh, Pennsylvania. Interestingly enough, you started your career as a mechanical engineer with a degree from Virginia Tech. And then that you earned an MD from Thomas Jefferson University in Philadelphia, Pennsylvania, completed a residency at the Medical College of Virginia in Richmond, and then you also have a training in biblical ministry from Columbia International University. You are currently an associate scholar for the Charlotte Lozier Institute. You're the vice chair of the board of directors of the American Association of Pro-Life Obstetricians and Gynecologists. You also are part of our scholar community here at Reasons to Believe, and you've published a number of peer-reviewed articles in the medical literature on the complications of medication abortions or chemical abortions. And then you also have taken a number of medical mission trips to different parts of the world, including Bangladesh, on a volunteer basis. So again, I can't think of a better person really to help us address this question of chemical abortions. Chris, I'm just interested, what made you decide to go to medical school? You were working as a mechanical engineer. So what caused you to shift careers?
Well, first of all, thank you for the kind introduction. When I was in high school, I always wanted to be a doctor. I always wanted to be in medicine. Medicine fascinated me. But when I was in high school and you look ahead at 12 years of training to become a physician, it just seems kind of overwhelming. I came from a family of engineers. I was good at math. I wanted to get a job. So engineering just seemed to kind of make sense. So I, got a degree in mechanical engineering. I worked in the nuclear power field for 7 years, but I never really liked it. It wasn't really my niche. Sometimes I joke that I wasn't smart enough to be an engineer, so I went to medical school. So I went and did what I always wanted to do and went to medical school. Before I did that, I actually volunteered. I became an EMT and volunteered after work on an ambulance. I felt like it was a big decision and I better make sure.
Yeah,
I really liked the medical field and I loved it. So I'm very happy. It was a good switch for me. I don't regret my years in engineering. I learned a lot there as well, but that's kind of my story.
Yeah. Yeah. Well, takes a lot of courage to make that kind of change. Um, why did you specifically decide to specialize in OBGYN medicine?
Yes, when I went to medical school, I would have never thought that would be what I would choose. I like the idea of continuity of care with my patients and getting to know people over their life. And I assumed I would go into primary care, family practice, or internal medicine. But in the last 2 years of medical school, you spend 6 weeks in each 6 weeks or so in different rotations and different specialties. And I found that I really liked being in the hospital and being in the action. And I didn't really, I liked the office, but I didn't really want to be there all the time. But, a lot of surgical subspecialties, you kind of do the surgery and then you never see the patient again. So obstetrics and gynecology is great because number one, you have this continuity of care with your patients over the long term. I see people from adolescence to, old age. In fact, I knew I was old when I actually saw a patient as a patient and she said, "You actually delivered me." So, but I also like the variety. Surgery in the operating room and then delivering babies, taking care of pregnant women, and then also in the office. So it wasn't what I was expected when I went to medical school, but I love the field of obstetrics.
Okay, so now, Christina, you are a committed Christian, and
Yes.
so how does your faith as a Christian really inform your work in medicine?
My faith definitely informs my work. So OBGYN is not an easy field to be a Christian because there are so many ethical issues. I remember in medical school, we're all talking about, well, what are you going to go into? What are you going to go into? And another student who was a Christian said, well, I know I'm not going into OBGYN because that is just too many ethical issues. I don't want to deal with that. And I thought, well, he's right, but that's not a good reason not to go into that. And shouldn't we have Christians in the field? And if God is real, if God isn't he big enough to help me? My faith definitely informs my work, and particularly in ethical issues, but particularly the biggest of those is abortion.
Mhm.
If you believe as I do that life begins at conception and people are made in the image of God, then it's not only abortion that's an issue, but also certain kinds of contraception. Is this an abortifacient? Does this kill a human being? I had to evaluate all of that. So it informs all of my work. I've committed my life to Jesus Christ. It informs everything I do, including as a physician.
So then, as a Christian OBGYN, do you perform abortions? Do you feel pressured to perform abortions? Because I'm under the maybe naive perception that there's a lot of pressure for medical students, residents, even practicing physicians to perform abortions because currently it's the law of the land.
I do not perform abortions. Both science and my faith inform the fact that human life begins at conception, and abortion is killing. It's not healthcare. As an obstetrician, I like to say I have two patients, the mother and the baby.
Mhm.
Now, I trained in the 90s. So I think that now there is a lot more pressure. I would say I personally never felt pressured to perform abortions. It's a harder issue in training when you're a medical student, particularly when you're a resident. When I interviewed for residencies, I kind of had to weave that into the discussion about, whether that was going to be okay that I don't perform abortion. So there's probably maybe places that didn't take me for that reason, or who knows. But I think now it is a very, very different environment, unfortunately.
Yeah.
And
Yeah.
there's a push to making doctors do that, which is simply wrong.
Yeah. Yeah. And then just maybe a more uplifting question here. What are some aspects of the process of human pregnancy or the birthing process, or even embryological development and fetal development that just cause you to go, wow, right? That just as a
Right. Well, the first wow has to be birth. I mean, I've delivered thousands of babies, but it's still amazing. It's an amazing process. The uterus is an amazing organ. I mean, it's like, we don't really think about the uterus being an amazing organ, but it is. It's the size of, smaller than my fist, and then grows big enough to hold a 9-pound baby, or 2 or 3 5-pound babies there. And then, the cervix and how it dilates, and the whole process. The placenta is amazing, how it nourishes the baby. It all points to a creator. But then in that moment of birth, and you have this hopefully screaming baby coming out, it's truly amazing. The other aspect is development. We study embryologic development, but you really can see that when I've had patients who have had a miscarriage, or maybe a stillbirth earlier in pregnancy, and you see this little tiny baby, too tiny to live outside the womb, but it's fully formed, and there's no question it's a human. And it's heartbreaking, but it also points to the creator, and that this is a precious human being.
Yeah. Yeah. Wow. Well, thank you. Okay. So let's go ahead and get into, some of the questions that deal with chemical abortions. And the first thing is probably, what is a chemical abortion? I don't know how many people are really familiar with the whole process of chemical abortion. So what is that precisely?
Good question. So there's lots of terms it's used by: chemical abortion, medication abortion, medical abortion, the abortion pill. Those terms would all refer to the same procedure. So the kind of typical original way that an abortion is performed would be surgically. Now, I'm referring in this discussion mostly to first trimester abortions, in the first, trimester of pregnancy. So before chemical abortion was approved, a first trimester abortion would be performed by a D&C, dilation, curettage, or dilation and evacuation. So dilate the cervix and then suction out the baby. A chemical abortion is done with medications to induce the loss of the baby. It's done with 2 medications, mifepristone, and then 1 or 2 days later, misoprostol, and it causes the fetal death, and it causes the uterus to contract and expel the baby. Now, I think the general not consensus, but maybe misperception is that, oh, well, that must be safer than having surgery. It's not. Actually, chemical abortion is less safe than surgical abortion. And there's such a push to make this, almost over the counter. There's online narratives of abortion at home is safer than Tylenol. Well, it's not. It's not even as safe as a surgical abortion. There's a lot of misinformation.
So then how common are chemical abortions?
They're very common. So they were approved in the United States in 2000. And at this point now, they are more than 50%. I think it's 54% of abortions are chemical abortions. And there, the last year of data, which I think was 2020, 930,000 chemical abortions in the United States. That's almost 1 million.
Yeah. Wow. Okay.
Yeah.
Very large number then. And then you mentioned that chemical abortions are actually less safe than a medical abortion. So what are some of the risks of chemical abortions? What are, some of the side effects, if you will?
Yeah, great question. And it's a very involved question. If we could talk first, let me explain how these work.
Okay, that'd be great. That would be great.
So there's 2 medications. They both begin with an M. They can be remembered because they're alphabetical. So the first medicine is mifepristone, also known as Mifeprex or RU486. Okay. So it's a progesterone receptor agonist. It works on the progesterone receptors in the uterus and basically works as an anti-progesterone. So progesterone is required to maintain a pregnancy. A pregnant woman, her body produces progesterone to maintain the baby. And so when you counteract that with an anti-progesterone, mifepristone, it kills the baby. So the woman takes that orally on the first day. And then 1 to 2 days later, She takes a second medication called misoprostol. Now that, or Cytotec, and that causes contractions to expel the baby. Now, misoprostol is actually a medicine used for people on long-term non-steroidal anti-inflammatory medications to prevent ulcers. We use it in obstetrics all the time for good reasons, inducing labor, preventing, treating postpartum hemorrhage. But in this case, it's used to expel the baby. So it's these two medicines. And so that's kind of how they work.
And they're administered several days apart from each other. Is that correct?
Correct. The one is given orally on, and then the second one is given actually buccally. So that's in the back of the cheek, 1 to 2 days later.
Okay. All right. And so then what would then be the risks of that particular procedure?
Well, that is a great question. And it depends on what studies you look at. So if we just talk about normal side effects, any medicine has side effects. So side effects, the typical experience, a woman take these medicines, she's going to have severe cramping and bleeding and maybe nausea, vomiting, abdominal pain. The product insert tells the woman expect to bleed 9 to 16 days. But 8% of women bleed more than 30 days. Now, this is just from the manufacturer admitting this. But, some women describe really severe, like labor pains and very heavy bleeding. And, then they're passing the baby at home. And then what do they do then? It's just a horrible situation. But now if we talk about, and that's if everything goes the way it's quote unquote supposed to go. But if we want to talk about complications, the two most common complications would be hemorrhage, maybe requiring transfusion, maybe requiring surgical completion. And the other most common would be retained tissue. So the woman passes the baby or some of the pregnancy, and there's still tissue left, and she will bleed. She will continue to bleed, she get infected, and that usually requires surgical completion. So those are common known complications. There's also risk of infection. There's also risk of, it's not a complication, but ongoing pregnancy. So sometimes these don't work the way they were intended, and the woman still has a live baby. And actually, studies have shown a fair number of women choose to keep their baby. But if she decides not to, then she's having a surgical procedure anyway. Another issue that happens is ectopic pregnancy. Now, ectopic pregnancy isn't a complication of the medications.
Right.
It's actually a contraindication to them. So an ectopic pregnancy is a pregnancy in the tube. And if you have a pregnancy in the tube, mifepristone and misoprostol won't treat that. If it's untreated, it ruptures, the woman hemorrhages. When I take a woman to the OR with a ruptured ectopic pregnancy, she has a belly full of liters of blood. So what has happened, there have been ectopic pregnancies. This medication should never be given to a woman with an ectopic pregnancy. But what's happening is it's being given without an ultrasound, without determining where is this pregnancy. I mean, there have been women who have died in the United States from ruptured ectopic pregnancies that were not detected when they took medication abortion. So that's kind of a summary. Now, if you look at, it depends really how common are those? We're taught, well, like I said, there's a narrative, it's safer than Tylenol. Well, it's not safer than Tylenol, and it's getting to be as easy to get as Tylenol, but it's not safer than Tylenol. If you look at US studies, it looks like, oh, maybe this is pretty safe. If you look at international studies, there's a different picture. I've taken a lot of these studies and really combed through them, and Fuzz, you know more than I that you can take data and make it show different things. So a lot of the US studies have a very high loss to follow up. So a lot of the studies only look at certain complications. So they say, well, one study said, oh, this is this percent complication rate. Well, no, it's this percent of those complications.
Right.
The other big flaw in the US studies is, and this is kind of the loss of follow-up issue is that the abortion providers, who are often the ones doing those studies, don't know of the complications. The women go to the ER and are treated otherwise. There was a study in Finland by Niinimäki, and in that study, so in Finland, they have a national health registry, so they can look at they have all the data on every abortion and what happened, and looked at them for 6 weeks. And they found that they were comparing medication or chemical abortion to surgical abortion. So women who had a chemical abortion, 15.6% of those women hemorrhaged, compared to 2.1% of women who had surgical abortion. And then incomplete abortion, so this means they need surgery, probably 6.7% in a medication or chemical abortion, compared to 1.6% in a surgical abortion. Infection was about 1.7% for both. But any complication, they found medication abortion, 20% of women had a complication, compared to 5.6% for surgical abortion. So, any procedure has risk of complications, but unfortunately, this is being promoted as, oh, it's safe, there's no problem, it's very safe. It's not. There's risks.
Now, are there long-term effects of chemical abortions? Has anybody studied kind of long-term side effects or long-term consequences?
Yes. Now, certainly those are harder to study, and they're not as well understood. There have been a lot of studies showing abortion and the relationship between abortion and preterm birth and a subsequent pregnancy. And of course, some of that data is denied, but now I will say most of those studies are looking at surgical abortions where there might be a particular mechanism for that. There is thought to be some relationship between a woman having a first pregnancy her first pregnancy and abortion, compared to a woman whose first pregnancy is a live birth, and it increased, almost doubles her risk of breast cancer. Now that data isn't quite as good as some of the others. Risk of placenta previa, and then there's the mental health. And again, there's, the link between mental health and abortion can certainly be difficult, because some of the factors that maybe influence a woman getting an abortion are a factor in her mental health. But, there was a study looking at 75 studies on abortion and mental health, and 65% of them showed a correlation. And then there is also maternal mortality. Women are more likely after an abortion, for the 108 days after abortion, to die compared to after a birth.
Wow. So this is definitely, regardless of what one believes about, abortion, I mean, this is pretty sobering data in the sense that, if 1 in 5 women that get a chemical abortion very likely are going to have some serious, side effects of that. So it's not something that should be done lightly or without a physician's, supervision, right? But my understanding is that, as you're saying, that chemical abortions are maybe inappropriately accessible to women. Could you speak a little bit about that?
Yes, and they are, and it's being pushed by the FDA. I'd like to just to review a little bit about the history of what the FDA and their restrictions, what they've done and their restrictions on medication abortion. So medication abortion was approved in 2000 under specific safety regulations. It was approved up to 49 days, 7 weeks gestation. It had to be prescribed by a physician. It had to be, there were 3 required office visits. The woman had to go on the first day. She had to go on day 3, and she had to go then 2 weeks after, at day 14. The physician had to be able to diagnose ectopic pregnancy and determine how far along she was. The physician had to make sure she had access to medical facilities for hemorrhage or for transfusion or for surgical intervention. And the medication could only be dispensed in a certain healthcare setting, and the woman had to get it in person. And the abortion provider had to report any adverse events, transfusion, hospitalizations, ongoing pregnancy, any serious event, and death to the FDA. So that's been really changing in the last 7 years. In 2016, the FDA, they increased the gestational age from 7 weeks to 10 weeks. Now, what that means, the farther along in pregnancy, the more complications of this intervention and the less chance it will do what they're trying to do. They also took, in fact, I have a slide to show, if we could, I'll bring that up.
Sure, that'd be great.
I think this will, let me. There we go. There we go. There we go. So this was what I explained in 2000. So in 2016, they increased the gestational age to 70 days. They dropped the office visit from 3 visits to 1 on a follow-up visit. So you don't even have to go in before you get the abortion. It no longer has to be a physician. It has to be a healthcare provider, which they don't really define. Still had to be dispensed in a healthcare facility. But at the same time that they changed these restrictions, they eliminated all reporting requirements except to report death. So I don't know how you can monitor the effect of these changes. And then in 2020 and 2021, with COVID, they said it didn't have to be dispensed in person, and they made that permanent in 2021. And also the other change is in 2021 is now it doesn't have to be dispensed in a healthcare facility. It can be dispensed in a pharmacy or by mail. And still, the only adverse event that has to be reported is death.
So how does the FDA justify this kind of significant change in the administration of chemical abortifacients?
That is a great question. So in April of 2021, when Janet Woodcock of the FDA wrote a letter to ACOG, American College of OBGYN, who has been pushing for this, and said they will not enforce the in-person requirement, she said, well, there haven't been a lot of adverse events reported. Well, of course there haven't, because you're not requiring reporting. And then also she said, well, we looked at these 4 studies, I believe, 4 studies, and they don't really show a problem with telemed abortion. And this, there's of course problems with the studies, and we're looking at 4 studies. So it's a great question. It's very concerning.
So you've actually published some articles as part of research teams, really looking at like the reporting of the side effects for these chemical abortions, right?
Yes. So this was an article, I was a co-author, Deaths and Severe Adverse Events After the Use of Mifepristone as an Abortifacient. So the manufacturer, so again, before 2016, the abortion provider was required to report any adverse events to the manufacturer, who then reported to the FDA, which is all kind of weird. So we actually, those are available by the Freedom of Information Act. So we got those reports, and actually there was a whole team of OBGYNs who coded these based on severity and looked at them. I spent hours just looking at each adverse event and coding them. And there's not that we found 3,197 unique adverse event reports, which isn't that many in 3.7 million medication abortions. But, we found some concerning things just in these reports and the care and what was missing. And we found that the abortion provider often wasn't the one taking care of the complication. Less than 40% of the D&Cs that were needed to complete the abortion or to stop bleeding were performed by someone other than I'm sorry. The abortion provider only performed less than 40% of those.
Mm.
So another study, if you'd like to go here next, this is not my paper. This is a paper by Cleland, where they looked at over 200,000 medication abortions by Planned Parenthood in 2009 and 2010. And this is the paper I referred to where they said only 0.65% risk of adverse event. Well, they only looked at 8 adverse events, 8 specific adverse events. They didn't look at the most common adverse events, the bleeding without transfusion. They didn't look at D&C if it was done at the clinic. And they based all of their data, for this study, on these adverse event reports that they had to send in. So they're only reporting what they know about. If a woman goes to the ER, a woman has bleeding, she goes to the ER, she has a D&C, and the abortion provider doesn't know about that. That's not even required to go to the FDA. The ER doctor isn't required to report that. So they're saying this, but what's interesting in this study, I was studying this study, and I had done the other paper, and I had looked at all these adverse event reports, and I said, this isn't right. They're saying we had, in 2 years, we had this many adverse events, and I know we didn't have that many in our paper. So just, to clarify, when this paper by Cleland was published, I'm sorry, the data they used was 2009, 2010. So they were required to report adverse events. So I and some colleagues went and pulled all the adverse events reports from 2009, 2010. And we found, so in that other paper where they say medication abortion is safe, in that 2-year period, in 200,000 some abortions, medication abortions, they say Planned Parenthood, they reported 1,530 adverse events. But if you go to the FDA adverse event reporting system online, there's only 664. And if you look at what they gave us when we asked for them by the Freedom of Information Act for that first paper, there's only 330. So a couple things here. We know that 1,530 is not valid. It's much higher than that. But even what they know and what they say they're reporting to the FDA or to the manufacturer and then the FDA isn't showing up in the FDA system. And when we as researchers are wanting to evaluate this and ask for them by the Freedom of Information Act, we're not getting all of that. So lots of concerns, as you can see.
So do you think this is an intentional suppression of data, or is it just methodological? And maybe that's not a fair question to ask you.
You know what? I can't make that judgment. I don't know. When I would look at the paper by Cleland and the discrepancy, did Planned Parenthood report to the manufacturer? Did the manufacturer not, did Planned Parenthood not report to the manufacturer? Did the manufacturer not report to the FDA? Did the FDA not report to to their dashboard? I don't know where the link broke down. I know their numbers are low, but I know that even what they're claiming isn't showing up in the FDA system.
Yeah.
So even when they were required to report adverse events, they're not accurate.
So when people are making the claim that, taking the pills for a chemical abortion is really no different than taking Tylenol, and then they're going to data from the FDA to justify that, people could sincerely think that's the case because of how low the numbers are, when in fact, in reality, the numbers are much higher than that. and the risk is much greater than for female patients. And again, as you're saying, what's being reported isn't the full range of side effects. It's really a subset of those, right?
Correct. The FDA said, I think it's 4,000, this number may be off. It's 4,000 something. I think it's 4,195 complications in their adverse event reporting system out of 3.7 million medication abortions from 2000 to 2018. That number doesn't make sense. Like, that's like 0.11%. Every intervention has complications.
Right.
So even if there were a 2% complication rate, I mean, we're missing like, we're only seeing, I think it's like 6% of what they're supposedly, is happening. It's just not, things aren't adding up. I don't know where the breakdown is, but I think we need to, women deserve to know the truth. And, even if you were to say that abortion is a woman's right, she should be treated medically appropriately.
Right. So there's really, again, the larger issue here isn't, again, whether you and I are uncomfortable with abortion because we see it as terminating a human life. The question here is that for whatever motivation, women are not being given appropriate medical care. That to me seems to be maybe the larger issue that should be concerning to everybody.
That is of great concern to me. And what's happening now is it's being pushed more and more, as you can see how the FDA has taken mifepristone abortions, medication abortions, and now it's being pushed online. And I mean, it's very easy to get a medication abortion, to get those pills.
Now, we are heading into the summer as we're recording this interview, and the thought is that the Supreme Court is going to overturn, in effect, Roe v. Wade.
Mm-hmm.
And if that's the case, it's easy to envision how chemical abortions may even become more commonplace.
Mm-hmm.
There might even be a black market of sorts that emerges.
Mm-hmm.
So speak a little bit to that. Is that a real concern? From your standpoint as a physician, how do you react to that possible scenario?
I would say there already is a black market. And as I said, the FDA is paving the way. So, I explained how they were, the whole process. And now there's a push toward telemed abortion, removing the doctor. Well, the doctor's already removed from the picture, but even we're removing the healthcare provider. So, a doctor's supposed to be, the provider's supposed to be able to tell where the pregnancy is and how far along the woman is. And there's not even an ultrasound required. There's not even a visit required. There's not even a physician required. And now it's actually very easy to go online and get the abortion pill through telemedicine. There is a site. It will ask you what your state is. And, some states have restrictions even now, like right now there's 32 states that require a physician. There's 19 that prohibit telemedicine. But you can go on this site and put in your state. Okay, your state, this is how you can get an abortion. You can get these pills, and they'll send you to other websites. I mean, you can put this pill in a shopping cart like you're buying something on Amazon.
Mm.
And it's problematic.
I mean, and so as a rule of thumb, self-managed medical care isn't advisable under, almost any circumstance,
Mm-hmm.
And so, again, what are your concerns, in general about, complications that can occur through self-managed abortions? And again, how is Roe v. Wade going to impact this, do you think?
Sure. Well, we talked about the complications before. Now, if you're talking about self-managed abortion or demedicalization or many forms of telemed abortion, we're looking at a whole new set of complications. So, for example, estimated gestational age. Medication abortions approved up to 70 days, 10 weeks. If it's given later, there's higher complications, there's less chance of quote unquote success. A lot of times online, it will ask, what was the date of your last menstrual period? How sure are you? It'll go by the last menstrual period, which we know is for many women not very reliable. So women, and this has happened. There was a big issue that happened in the UK when women had, if women think they're 8 weeks and they're really 13 weeks, they're going to have more complications. The other issue is ectopic pregnancy. They online, I've gone through these websites, the online, to see how they do it. And they will say, well, do you have any risk factors for ectopic pregnancy? No. Have you ever had an ectopic pregnancy? So they screen that by risk factors, but great proportion of women with ectopic pregnancy don't have risk factors. The only way to tell where the pregnancy is to have an ultrasound. To be given this medication without an ultrasound is unconscionable.
Yeah.
And then there's the whole ROGAM, RH status. So 15% of women in North America are RH negative. They have a negative blood type. And any woman with a negative blood type in any pregnancy, miscarriage, abortion, ectopic, live birth, we give a ROGAM. It's basically I hate to say vaccine because it's a bad word now, but prevents the baby from forming the woman from forming antibodies and causing problems in a future pregnancy. Well, if the woman's getting this online and she happens to be RH negative and she has abortion and she doesn't get ROGAM, and then in a future pregnancy can cause problems. I think another issue is access to care. So this is being pushed, access is being pushed, particularly for women maybe who are farther away from a facility. But that's the problem. When it was approved, they had to have access to a facility. We already know that abortion providers aren't caring, many of them, for their complications. So what's going to happen when there is no abortion provider? The woman has hemorrhage at home, while you or I may live close to an ER, but some women don't. And they're going to end up in the ER. I think the other issue, there's some other domestic issues like domestic violence, which studies have shown this is about 4 times higher in unwanted and pregnancies and women seeking abortion. So, as physicians, we're supposed to screen for this. We're supposed to screen for this, particularly in women seeking abortion. How do we screen for this? And then there's traffickers and reproductive coercion. So there have been in the news, many cases or a handful of cases at least, where a man's gotten a medication abortion pill for her girlfriend and put it in her drink to induce the pregnancy. Well, they shouldn't have access to this. And then with women who are trafficked, we know that women who are trafficked are getting abortions. Many of them are forced abortions. And, women who are trafficked, one of the few places they actually show up is to a healthcare provider. And as healthcare providers, we're not really very good about detecting these women, but that is a rare opportunity for them. And if we're missing that opportunity, it's just going to be more forced abortions.
Yeah.
And the other thing is informed consent. As a physician, I need to tell my patient, these are the risks, these are the benefits, these are your options. How do you do that online?
Yeah. Yeah.
I think it's a very concerning scenario. And with Roe v. Wade, like I said, it's being pushed. So if your state decides outlaws abortion, then they're providing other avenues for you to get it through the mail.
Yeah. Yeah. So a couple more questions. And then I want to ask you just a few philosophical questions as well. can chemical abortions be reversed, and how successful are these reversals if they can be reversed?
Yeah, that's a great question. Yes, sometimes they can be reversed. I'd like to pull up another slide here. Let me get this slide. So in some cases, a medication abortion can be reversed. Now, as we discussed, the first medication is an anti-progesterone, mifepristone. And sometimes after the woman takes that medication, she changes her mind. And there have been some studies where they've looked at giving those women progesterone to overcome the anti-progesterone effects of the mifepristone. And what they have found is that in about 2/3 of the cases, the baby can be saved.
Mm.
Now, if the woman simply, let's say she takes the first medicine, changes her mind, and doesn't take the second medication, misoprostol, about 25% of the time, the baby will live.
Mm.
If she takes, the high dose progesterone, it's up to about 2/3 of the time. So this is a website I want to show, abortionpillreversal.com. This is a network of physicians. It's not, it's totally above board physicians who are trained in this. And I believe this site would connect you to a local physician who would be able to manage this if someone, if they're in that situation.
Yeah. Okay, well, Chris, thank you so much. As we get ready to kind of close the interview, this has been incredibly informative, and I've learned a ton of things I didn't know about chemical abortions and how they're administered and what the potential side effects are. Couple of philosophical type questions. You mentioned that, you take the view that human life begins at the point of conception, which is a view that I would share with you. But what do you say to somebody who's a pro-choice advocate who says, well, yes, indeed, an unborn child is a human biologically speaking, but it's not a person.
Mhm.
That it however they go define, what a person is, the claim is that it's not a person, therefore abortion really isn't terminating a human life in that sense.
And that is the narrative now. This is, okay, it's a life. You used to say it's not a life. Okay, it's a life, but it's not a person. Well, then when does personhood begin?
Mm.
If the baby, the toddler crawling around your living room is a person, and the baby I just delivered is a person, is the baby that is about to come out not a person?
Mm.
We know that gestation is 40 weeks, and now babies as early as 22 weeks can live outside the womb. So do we say that's a person? But do we say that 2 hours before it's born, it's not a person? There's no event that happens. I mean, this is clearly, I believe this is a human being born, in the image of God.
Yeah, well, and there's a challenge, I think, scientifically speaking, defining, it's not even just where do you the limit when a person begins and ends, but scientifically, how would you actually go about defining a person? It seems like it really is a philosophical decision as to what you're going to determine as a person, and that feels a bit arbitrary to me.
Right. Yeah, and I would suggest also, if it does become a person somewhere in there, which I don't believe, but who am I to make that decision and potentially kill a human being? We have to, I believe that it's a person, he or she is a person at conception. But even if you didn't believe that, I think you'd have to err on the side of saying it is a person at conception, because where else
Right.
can you arbitrarily choose that?
Well, I mean, that the point of conception is where the great discontinuity takes place, where you now have, as a result of that event, a unique individual, right? And that is has the capacity to grow and develop into a fully developed, fully formed human being. But that's the point of discontinuity in my mind.
Right.
Yeah. All right.
Yeah.
Well, one final question, Chris, and this is maybe is appealing to your training in ministry. What would you say to someone, both men and women, who've been involved in an abortion? And maybe they've come to regret this, or they feel like because they've been involved in abortion that that they've done that which is unspeakable, that which can't ever be forgiven. What would you say?
Great question. And abortion is very common. So I'm sure who are listening to this are in this situation. And I would say, first of all, that God offers forgiveness and healing. Some are trying to promote abortion as a wonderful thing. We've heard, shout your abortion. I love abortion. The truth is, women carry these scars for a long time. When I take a history on a patient, how many pregnancies, how many deliveries, how many miscarriage. I mean, when they talk about abortion, almost without exception, there is a change in their countenance. You can see that there's discomfort there. And so I think that many women do feel guilt and shame and regret. And I would say there's forgiveness and healing in God. And there is a lot of resources out there, a lot of resources for women who have had an abortion. And I encourage people to seek a counselor, to share your story with someone you can trust, to check out some of these resources. I think there's Rachel's Vineyard, Stand Up Girl. There's many, many resources out there, and God offers forgiveness and healing.
Yeah. Well, Chris, thank you so much for taking the time to be with us, and again, sharing your invaluable insight into this really difficult question. Are chemical abortions safe? And I've learned a lot, and I hope our viewers have learned a lot as well. And really, I think the ultimate motivation for this particular episode is really getting good information in the hands of everyone, regardless of their particular perspective on abortion. And though both you and I are pro-life, we want to make sure, above all, that really women are well treated, and that really they have the access to the best possible medical care. And that, again, is a real motivation for this episode. And I, when we chatted before this episode, I was just shocked to learn how common chemical abortions are, but B, really how dangerous they are. So thanks again for helping us, with this challenging question. For those of you that are watching this and you're interested in getting more resources on this whole issue of abortion and the whole idea of a pro-life position from a scientific, philosophical, and biblical perspective, I would invite you to check out a special page on our website at reasons.org. And that special page is entitled, let's see here, Human Value in Scripture, Science, and Society, where there's a collection of blog articles and videos and interviews that we've done that relate to pro-life questions. And we're going to be continuing to populate this page with resources that we'll be developing over the course of the summer. Chris, this interview will be on that page as well, as long as, and also will be released through our YouTube channel and on our Facebook page. And to get to that site, you can go to reasons.org and just search human value, or the URL is reasons.org/human value, as all one word. Mm-hmm. I just want to say thank you to our listeners. If you've really got a lot out of this particular episode, please share it with friends and people that are part of your sphere of influence. And I just want to leave people with this thought that the more that we discover about science, the more that we have reasons to believe. So again, check out our website, reasons.org, and check out the human value page. Also, follow us on social media, RTB_official. And if you are interested in subscribing to our YouTube channel, it's Reasons to Believe. Hit the subscribe button and you'll get access to a lot of great resources dealing with science, faith issues. And last but not least, don't forget to set a reminder so that you are notified when the next episode of Star Cells and God drops. And so again, until next time, I hope all of you stay safe and are healthy and remain in good spirits. God bless you. Thanks a lot, Chris.
Thank you so much.